Vulvovaginal candidiasis recurrent treatment. Vulvovaginal candidiasis, VVC, is a significant health issue affecting approximately 75% of women at least once in their lifetime, with 40 to 50% experiencing recurrent episodes. The pathophysiological mechanism involves an overgrowth of Candida species, primarily Candida albicans, in the vaginal microbiome. Key diagnostic approaches include a combination of clinical evaluation, wet mount microscopy, and fungal culture. Primary management strategies involve antifungal medications, with fluconazole being a commonly prescribed treatment. Recurrent VVC requires a more comprehensive approach, including prolonged antifungal therapy and consideration of underlying predisposing factors. Key points. Note: the prevalence of VVC is estimated to be around 29.2% in the general female population, with a significant increase to 57.5% in women with diabetes. Candida albicans is responsible for approximately 85 to 90% of VVC cases. The IDSA recommends fluconazole 150 mg orally as a single dose for the treatment of uncomplicated VVC, with a cure rate of 80 to 90%. Recurrent VVC is defined as 4 or more episodes of symptomatic VVC in a single year, affecting around 5 to 8% of women. The use of antibiotics increases the risk of developing VVC by 2.5-fold. Pregnancy is a significant risk factor for VVC, with an estimated 30% of pregnant women experiencing an episode. The sensitivity and specificity of wet mount microscopy for diagnosing VVC are 40 to 60% and 90 to 100%, respectively. Fungal culture has a sensitivity and specificity of 70 to 90% and 90 to 100%, respectively, for diagnosing VVC. The WHO recommends using clotrimazole 100 mg vaginal tablet for 7 to 14 days as an alternative treatment for VVC. The NICE guidelines suggest that women with recurrent VVC should be offered a 6-month course of fluconazole 50 mg orally once weekly. Overview and epidemiology. Vulvovaginal candidiasis is a fungal infection caused by Candida species, with Candida albicans being the most common pathogen. The global incidence of VVC is estimated to be around 138 million cases per year, with a prevalence of 29.2% in the general female population. In the United States, the estimated annual incidence is around 1.4 million cases. VVC affects women of all ages, with the highest incidence occurring in women of reproductive age, 15 to 49 years. The economic burden of VVC is significant, with estimated annual costs ranging from $1.4 billion to $2.8 billion in the United States. Major modifiable risk factors for VVC include antibiotic use, relative risk, 2.5, oral contraceptive use, relative risk, 1.5, and diabetes, relative risk, 2.5. Non-modifiable risk factors include pregnancy, with an estimated 30% of pregnant women experiencing an episode of VVC. Pathophysiology. The pathophysiology of VVC involves an overgrowth of Candida species in the vaginal microbiome, leading to an imbalance in the normal flora. Candida albicans is a commensal organism that is normally present on the skin and mucous membranes. However, in certain conditions, such as antibiotic use or immunosuppression, the balance of the microbiome can be disrupted, allowing Candida to overgrow and cause infection. The disease progression timeline typically involves an initial colonization of the vagina by Candida, followed by an overgrowth of the organism and the development of symptoms. Biomarker correlations, such as the presence of Candida-specific antibodies, can be used to diagnose VVC. Organ-specific pathophysiology involves the invasion of Candida into the vaginal epithelium, leading to inflammation and the development of symptoms. Clinical presentation. The classic presentation of VVC includes symptoms such as pruritus, 90%, vaginal discharge, 80%, and dysuria, 50%. Atypical presentations can occur, especially in elderly, diabetic, or immunocompromised women. Physical examination findings include erythema, 80%, edema, 60%, and a white, cottage cheese-like discharge, 50%. The sensitivity and specificity of physical examination findings for diagnosing VVC are 60 to 80% and 80 to 90%, respectively. Red flags requiring immediate action include severe symptoms, such as heavy bleeding or severe pain, and signs of systemic infection, such as fever or tachycardia. Symptom severity scoring systems, such as the VVC symptom score, can be used to assess the severity of symptoms. Diagnosis. The diagnosis of VVC involves a combination of clinical evaluation, wet mount microscopy, and fungal culture. The step-by-step diagnostic algorithm includes 1. Clinical evaluation, 2. Wet mount microscopy, and 3. Fungal culture. Laboratory workup includes specific tests, such as the KOH preparation, which has a sensitivity and specificity of 50 to 70% and 90 to 100%, respectively. Imaging, such as ultrasound, is not typically used to diagnose VVC. Validated scoring systems, such as the VVC symptom score, can be used to assess the severity of symptoms. Differential diagnosis includes other causes of vaginitis, such as bacterial vaginosis or trichomoniasis, which can be distinguished by the presence of specific symptoms and laboratory findings. Management and treatment. Emergency stabilization involves the treatment of severe symptoms, such as heavy bleeding or severe pain. Monitoring parameters include vital signs, such as temperature and blood pressure, and laboratory findings, such as complete blood count and blood chemistry. Immediate interventions include the administration of antifungal medications, such as fluconazole, and the treatment of underlying conditions, such as diabetes or immunosuppression. The IDSA recommends fluconazole 150 mg orally as a single dose for the treatment of uncomplicated VVC, with a cure rate of 80 to 90%. The mechanism of action of fluconazole involves the inhibition of fungal cell wall synthesis. Expected response timeline is typically within 3 to 7 days. Monitoring parameters include liver function tests and complete blood count. Evidence base includes the results of several clinical trials, including the fluconazole vaginal candidiasis study, which demonstrated a cure rate of 85% with fluconazole. Key points: pregnancy. The safety category of fluconazole during pregnancy is C, and the recommended dose is 150 mg orally as a single dose. Monitoring parameters include fetal monitoring and liver function tests. Chronic kidney disease. The recommended dose of fluconazole in patients with chronic kidney disease is 50 to 100 mg orally once daily, with a maximum dose of 200 mg orally once daily. Hepatic impairment. The recommended dose of fluconazole in patients with hepatic impairment is 50 to 100 mg orally once daily, with a maximum dose of 200 mg orally once daily. Elderly. Greater than 65 years. The recommended dose of fluconazole in elderly patients is 50 to 100 mg orally once daily, with a maximum dose of 200 mg orally once daily. Complications and prognosis. Major complications of VVC include the development of recurrent episodes, with an estimated 5 to 8% of women experiencing 4 or more episodes per year. Mortality data is limited, but the estimated mortality rate for VVC is less than 1%. Prognostic scoring systems, such as the VVC symptom score, can be used to assess the severity of symptoms and predict outcomes. Factors associated with poor outcome include the presence of underlying conditions, such as diabetes or immunosuppression, and the development of recurrent episodes. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the approval of the antifungal agent, posaconazole, for the treatment of VVC. Updated guidelines include the IDSA guidelines for the treatment of VVC, which recommend the use of fluconazole as first-line therapy. Ongoing clinical trials include the study of new antifungal agents, such as isovuconazonium, for the treatment of VVC. Novel biomarkers, such as the detection of Candida-specific antibodies, can be used to diagnose VVC. Precision medicine approaches, such as the use of genetic testing to identify underlying predisposing factors, can be used to tailor treatment to individual patients. Patient education and counseling. Key messages for patients include the importance of practicing good hygiene, avoiding tight-fitting clothing, and seeking medical attention if symptoms persist or recur. Medication adherence strategies include the use of reminders and the provision of written instructions. Warning signs requiring immediate medical attention include severe symptoms, such as heavy bleeding or severe pain, and signs of systemic infection, such as fever or tachycardia. Lifestyle modification targets include the avoidance of sugary foods and the consumption of yogurt containing live cultures. Follow-up schedule recommendations include a follow-up visit within 1 to 2 weeks after treatment to assess response to therapy. Clinical pearls. Note: the diagnosis of VVC should be based on a combination of clinical evaluation, wet mount microscopy, and fungal culture. The use of fluconazole as first-line therapy for VVC is recommended by the IDSA. The development of recurrent episodes of VVC is a significant complication, with an estimated 5 to 8% of women experiencing 4 or more episodes per year. The presence of underlying conditions, such as diabetes or immunosuppression, is a significant risk factor for the development of VVC. The use of antifungal agents, such as clotrimazole or miconazole, can be used as second-line therapy for VVC. The practice of good hygiene, including the avoidance of tight-fitting clothing and the use of breathable fabrics, can help prevent the development of VVC. The consumption of yogurt containing live cultures can help maintain the balance of the vaginal microbiome and prevent the development of VVC. The use of genetic testing to identify underlying predisposing factors can be used to tailor treatment to individual patients. The detection of Candida-specific antibodies can be used to diagnose VVC. References. 1. Cornley OA et al. Global Guideline for the Diagnosis and Management of Candidiasis, an initiative of the ECMM in cooperation with ESHM and ASM. The Lancet. Infectious Diseases. 2025, 25, 5E280E293. PMID, 399562121, https://pubmed.ncbi.nlm.nih.gov/399562121. doi, 10.1016/S1473-3099, 24, 00749-7. 2. Cook G. et al. Treatment for Recurrent Vulvovaginal Candidiasis, thrush. The Cochrane Database of Systematic Reviews. 2022, 1 CD 009151. PMID, 35005777, https://pubmed.ncbi.nlm.nih.gov/350057777. DOI 10.1002/1465185.cd009151.pub2. 3. Nyergesi P. et al. Vulvovaginal Candidiasis, a review of the evidence for the 2021 Centers for Disease Control and Prevention of Sexually Transmitted Infections Treatment Guidelines. Clinical Infectious Diseases, an official publication of the Infectious Diseases Society of America. 2022, 74, supple_2S162S168. PMID, 35416967, https://pubmed.ncbi.nlm.nih.gov/3541667. DOI 10.1093/SID/SIAB1057. 4. Mitchell CM, Assessment and Treatment of Vaginitis. Obstetrics and Gynecology. 2024, 144, 6765-781. PMID, 389912118, https://pubmed.ncbi.nlm.nih.gov/389912118. doi 10.1097/AOG.0000000000005673. 5. Sobel J.D. et al. Bacterial vaginosis and vulvovaginal candidiasis pathophysiologic interrelationship. Microorganisms. 2024, 12, 1. PMID 3825794. https://pubmed.ncbi.nlm.nih.gov/3825794. DOI 10.3390/microorganisms 120101008. 6. Busali V.B. et al. Vulvovaginal Candidiasis, an overview of current trends and the latest treatment strategies. Microbial pathogenesis. 2025, 200:107359. PMID 399211042. https://pubmed.ncbi.nlm.nih.gov/399211042. DOI 10.1016/j.micpath.2025.107359. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.